Hello, my name is Dr. Yessa Tuakli. My co-presenter is Dr. Yelena MacLeod, and it's our joy today to present our study, leveraging the ACEs framework to strengthen safeguarding in youth sport. Yelena and I represent the University of Pittsburgh, the Yale School of Public Health, and the Sports Equity Lab. We have no conflicts of interest. In the past few weeks, you've probably seen a headline like this, describing systematic abuse of athletes in gymnastics, football, swimming, and other sports. These stories are often painted as emotional vignettes where feelings outweigh facts, when in reality, the science of interpersonal violence in sport should outweigh its emotional and political pull. We know that adverse experiences in childhood and interpersonal trauma are associated with a cascade of negative health outcomes in adulthood. Everything from health-related risk factors to disease conditions are possible. The ACEs framework, so to speak, has in fact been vetted for the past 20 years. Now, sport is a microcosm of society. Naturally, therefore, adversity and interpersonal trauma impact young athletes' lives too. Fortunately, this reality is slowly setting in, thanks in large part to those news stories we showed at the beginning of the presentation, and safeguarding, as it's called, is increasingly a priority for the global sports and exercise medicine community. That said, there are gaps. And so in this talk, we will describe two things. One, the current state of play in the sport safeguarding science. And two, our proposal for integrated athlete care, where trauma-informed principles and practice are part of the day-to-day clinical pathway. Last fall, for the first time in 23 years, experts at the global Play the Game conference identified abuse as the single biggest threat to modern sport. The USA gymnastics abuse tragedy certainly helped catapult this reality to the fore, but abuse in sport has been debated in academia for nearly 40 years. So it's not new, but thanks to media, it's becoming a new priority. Here's what is known. A real or perceived power imbalance anchors every form of abuse in sport. It's not only a matter of gender and age. A range of factors make psychological abuse especially common in sport, including unwritten social contracts that demand athletes grin and bear it, walk it off, and see pain as gain. And of course, sexism, racism, ableism, and other societal biases exist in sport too. Now, the best available data tell us that 75% of youth have experienced psychological abuse in sport in the UK. Between 19 and 92% of elite athletes have experienced sexual abuse in Canada, and globally, athletes with disabilities are between 2 and 4 times greater risk of intentional harm. This is due to a variety of factors that may put the athlete at an inherent power imbalance relative to the people around them. And these include an additional layer of daily personal care needs that athletes with disabilities have, athletes without disabilities do not have, responsibilities among the entourage potentially becoming blurred, and then athletes being infantilized, i.e. treated like perpetual children. So there's no real consensus definition yet, but scientists in this field are leaning towards the term intentional violence or interpersonal violence to connote volitional acts that result in or have the potential to result in physical injury and or psychological harm. The consequences of abuse in sport are myriad for both the athlete and their organization. I'll just highlight the two extremes. Abuse can lead to everything from discouragement and sport dropout to suicide. Appropriately, sports organizations are increasingly promoting safe sport, which is an athletic environment that is free from all forms of harassment and abuse. Now, the US Center for Safe Sport was established in 2017, and a key feature of it is the Central Disciplinary Database. Prior to the Central Disciplinary Database, each sport had its own disciplinary process and procedure. Most of the US Center for Safe Sports data is publicly available, and includes information on the perpetrator only. As you can see from this chart, the number of abuse cases jumped in 2017 once the center was established. So sports are using it. Even in sports and exercise medicine, current approaches to safeguarding rely almost only on reporting. And therefore, these approaches are based on fallacious assumptions of common sense. So what do I mean by that? The underpinning assumptions here are that the vast majority of people in the sports environment, everyone from the coach to the trainer to teammates, will, number one, mean well, and number two, naturally recognize abuse when they see it. And as we all know, neither are true. Outpatient pediatric sports medicine environments have yet to incorporate routine trauma screening, trauma care, or collaboration with non-sport centers or sports centers like Safe Sport. And this is the challenging elephant in the room. Can trauma-informed care be integrated into pediatric sports and exercise medicine settings? I'll now turn it over to my co-presenter, Dr. MacLeod.
All right, so we propose an innovative program, Integrated Athlete Care, as a sorely needed solution. Our mission is as follows: to integrate trauma-informed care with pediatric sports medicine settings, to empower and heal children and families who have experienced trauma while practicing sport, and finally and importantly, to restore a love of sports. As part of our program, we will be offering universal screening for ACEs and trauma symptoms as a precursor for appropriate services and support for children and their families experiencing abuse in sports settings. These services will range from resiliency building and psychoeducation to mental health services in children and adolescents who are symptomatic from their trauma exposure. Prior to opening, we plan to liaise with local youth-serving organizations to create a centralized inventory of local services for children engaged in sport. Along with a network of community services, we hope to engage a network of mental health providers, ranging from sports psychology to psychiatry. Our focus once we launch will be on training providers in trauma-informed care, establishing sensitive and appropriate intervals for ACEs and symptom screening, creating educational and resilience-building materials for families, and streamlining referrals to care coordination, social work, behavioral health, and group therapy. All of these processes will be iteratively honed with regular feedback from providers, families, and ancillary staff. Cost-benefit analyses and associated quality improvement projects will also allow us to establish program outcome metrics and compare them against existing state, national, and international data. Longitudinally, we hope to contribute towards an international community of pediatric providers engaged in trauma-related screening and care pertaining to youth engaged in sports. While local networks provide a critical infrastructure for referrals and for education, broader remote learning communities, such as the Extension of Community Healthcare Outcomes or the ECHO project, can also promote connectedness and information sharing. Importantly, given the lack of accurate incidence and prevalence data on abuse and trauma in youth sports, we hope to contribute to the field with regular digitized data collection in safe spaces, and importantly, with appropriate aftercare. There are some challenges that we anticipate, and a major one is posed by the lack of reliable empirical data on the prevalence of athlete physical, psychological, and sexual abuse. Estimates of program size, cost, and scope ahead of launch are therefore limited. Engaging pediatric primary care providers and digitizing data collection to reduce disruption in workflow can help overcome some of these difficulties, as can rapid iteration of service models as we learn more about needs specific to our community of patients. A more insidious barrier comes from sports culture itself, a focus on grinning and bearing it, high performance, and outcomes over well-being permeate sports-affiliated medical settings and policies as well. Essentially, organizational permissiveness to trauma-informed philosophy may be low, which could hinder implementation. Relatedly, sports psychologists are a rare resource, which makes it difficult to provide specialized athlete care following trauma. Involving other pediatric specialties, however, can help overcome all of these barriers. There are many important advantages and strengths to involving pediatric providers in the early detection of trauma within sports settings, and in doing so within the ACEs framework specifically. Pediatric providers are particularly attuned to early detection, intervention, and prevention when working with their patients. When it comes to trauma-informed care, the ACEs framework is already well known to many outpatient providers, and training and support are easily accessible and free. Asking about trauma exposure in medical settings rather than in athletic environments allows for a safe, normalizing environment to discuss and problem solve. Epidemiologically, we're also more likely to obtain accurate estimates of incidence and prevalence of child abuse in sports that will allow us to understand the scope of the problem and engage stakeholders in intervention. Importantly, the ACEs framework allows for brief interventions based on level of need, ranging from resilience building, social determinants of health-related interventions, psychoeducation, and referral to mental health services if children are symptomatic. Finally, creating a safe space to talk about abuse in sports opens the door to novel therapeutic modalities that emphasize teamwork, camaraderie, and other values that are inherent in sports culture. A couple of next steps that I wanted to point out to you. Within the constraints of a busy outpatient clinic, the one important thing to keep in mind is that the onus should not be on the pediatric providers alone to screen for trauma and engage in intervention. Team infrastructure and systems design are key components to ensuring that trauma screening is plausible, thoughtful, and actionable. Ongoing collaborations with social work, care management, and care coordination are critical components of ensuring that screening is meaningful and that children and their families are referred appropriately. Potential outcomes of screening that need to be addressed include mandated reporting, clinical referral, or involvement of community-based youth organizations. Now, patient-entered questionnaires that are linked to the electronic medical record also provide an opportunity for patients to express themselves with more time and more privacy without negatively impacting workflow. Decision support for pediatricians unfamiliar with trauma in sport is critical and includes built-in screening and referral pathways, as well as frequent co-education and training with athletes and experts in trauma. Finally, robust and regular data collection on the prevalence and features of trauma in youth sport can help us move towards predictive analytics that link trauma exposure to psychiatric and performance outcomes. Fundamentally, sport is far from immune from interpersonal violence against children. Children experiencing abuse in sports deserve access to the plethora of evidence-based ACEs and trauma-informed care work, and pediatric providers are the key to bridging the gap. Thank you so much for your time and for your attention, and please feel free to reach out to either one of us with any questions.